Hello, and welcome to another educational session on topics in peripheral nerve surgery. This is sponsored by the AANS CNS section on disorders of the spine and peripheral nerves. My name is Jared Pisapia. I'm a neurosurgeon at Westchester Medical Center in New York. We're joined by Dr. Rizk, a neurosurgeon at the University of Texas at Austin. And we're very pleased to welcome Dr. Lara. Dr. Lara is a physical medicine and rehabilitation physician, also at the University of Texas at Austin. He'll be presenting today on postoperative considerations from a physiatry perspective after brachial plexus surgery, including nerve transfers. So this is an area that, as neurosurgeons, we don't get as much training or exposure in. So, Dr. Allen, really looking forward to hearing from you. So thanks again for joining us.
Yeah, thank you for having me. So with that said, a little bit of background just to add on for me. As a rehab specialist, I do enjoy working in the neuromuscular aspect of field. So peripheral nerves is a big topic of interest for me. And so when I got asked if I could do this, by all means, I was very excited to jump on and be able to help and guide specifically postoperative rehabilitation. So a little bit about what we're going to be talking about today is going to be what is it that we need to do in order to have successful surgeries after these peripheral nerve injuries. I am a pediatric specialist, and so I think it's important for me to mention neonatal, which is also BPBI, also known as brachial plexus birth injury, in addition to those that are in the adult world or older children, which are not necessarily related to the time of birth. I'm Alan Lara from, like he said, UT Health Austin, and we can get started. So disclosures and objectives. I don't have any disclosures today. Some of the objectives are going to be to summarize surgical timing, injury patterns, nerve transfer strategies. That'll be just a quick review. I hear that we've already gone over some of these topics, so I'm just going to focus more on the post-operative section. I do want to present some evidence-based nerve transfer outcomes and selection criteria. Understand when and why free functioning muscle transfer is indicated. With wearing my neuromuscular hat, I also perform electrodiagnostic studies with our neuromuscular neurologist here at Dells. So also I'll talk about the importance of utilizing electroddiagnostic testing for surgical planning and postoperative monitoring. We'll talk about coordination of postoperative rehab protocols, including EMG biofeedback, implementation of multimodal pain management for chronic neuropathic pain, which can be seen in some of these specific cases. I'll review those. And then establish multidisciplinary collaboration across all recovery phases. As a rehab doc, I live in the multidisciplinary world, so being able to collaborate not only with paraprofessionals, but other medical professionals as well, which is pretty good. Each objective addresses, like I mentioned, we'll be talking about both in babies and those who are older kids / adults. So those two populations, we got to make those key distinctions. Let's talk about the incidence rate specifically for this brachial plexus injury. In children, about 0.3 to 3 out of 1,000 births tend to occur with a brachial plexus birth injury. The one interesting fact specifically with babies is that a good 2/3 to 3/4 will spontaneously recover without the need of any further surgery. It's those 1/3 to 1/4 that are those tricky situations that are right on the fence where having a rehab and a multidisciplinary kind of helps in directing this. For babies specifically, rehabilitation, it begins immediately at diagnosis. And so here at Dells, we have a connection with our NICU that as soon as we've identified anyone with any sort of shoulder dystocia at the time of birth or any sort of limb arm that's not activating, they will automatically refer them over to my clinic so that I can at least start with education and stretches. The one thing with babies is that neuroplasticity, so superior cortical plasticity, about 100% of them achieve complete cortical reorganization after nerve transfers. So if we are to consider for those few that do need a nerve transfer in the babies, they tend to have very good outcomes when it comes to the functional goals that we're trying to obtain. Now, in the older population and those that are past the time of birth, these tend to be due to more of these high energy mechanisms. We're talking about motor vehicle accidents. We're talking about stingers like in football, in sports. It could be from a fall onto an outstretched hand. The thing with these is that the spontaneous recovery is far less common as compared to pediatrics, going back to that neuroplasticity. There's also higher rates of avulsion. This could be due to some theories that maybe the baby's nerves are a little bit stretchier than those in adults, a little bit more fixed. So because they're also high energy, it'll be a higher risk of a more of a severe injury as well. Specifically with this population, rehabilitation will be mostly in the post-operative perspective. In comparison to kids, their cortical plasticity is only about like half of achieving complete reorganization. And that's because a lot of the pathways in the brain have already been established where babies have that ability to build new ones. So age is the only significant predictor of plasticity. So the younger, the better. So babies are great. So quick review. Like I said, this is something that I'm just going to touch on briefly, some major planning for surgical things that we need to keep in mind, specifically in babies. Time frame is very, very important. Surgical reconstruction is usually looked at between the ages of 3 to 9. There is multiple functional scales that we do look at to kind of help us in determining those that are having poor spontaneous recovery versus those that are having better spontaneous recovery. And so the cookie test, it's just a test where we give a child a cookie and can they bring that cookie to the mouth? And so the biggest thing that we're looking for in babies is the ability to flex that elbow. If I'm not having elbow flexion by like 6 to 9 months, I am having conversations with our neurosurgeons about potential surgical options to help them out, whether that's a nerve transfer or other. As for traumatic, the optimal window is a little bit smaller, again, because the recovery process is more fixed at this point. They usually need to be operated within that 3-month period. We don't have that leverage up until that 9-month where we have that neuroplasticity to depend on. The more that you wait, the less likely that you are to gain any sort of functional strength. The highest is seen with muscle strength testing of a 3 or more, specifically when we're operating within the 3-month period. So with the adults and older kids, it's important for us to intervene much sooner, where with the babies, we have a little bit more time. Several different procedures for depending on which joint is affected. So if we're talking about the shoulder, it could be a spinal accessory nerve to a suprascapular nerve with triceps branch, plus or minus, depending on the involvement. Could also go to the axillary nerve in the adults or the motor pectoral nerve. Specifically in babies, we like to use that axillary nerve to help us out as well. If we're looking more at that elbow, we're looking more at double Oberlin, double fascicular nerve transfers. And then if you have just a complete panplexus avulsion, usually we don't, we'll reach for nerve transfers at this point. We're looking more of that free functional motor muscle transfer. And so this is where I then start having to also discuss with either in the pediatric world, it could be pediatric plastics that help us with any sort of muscle tendon transfers, or in some places it could also be a pediatric orthopedic who does it. So it just depends on facility for those. So, like I said, we would be talking about some nerve transfer outcomes, evidence-based section. Like I mentioned, we'll go through both of those different joints. Looking at the research, there has been some meta-analysis that has combined 29 different studies with a total of 393 patients, showing spinal accessory and spinal and suprascapular nerve plus the lateral head of the triceps and the axillary nerve showed the highest rates of satisfactory abduction and external rotation, and the highest means of range of motion values. Double will always triumph a single nerve transfer for the shoulder function from what we've seen in these outcomes with these patients. They are outperforming single transfers for abduction outcomes and range of motion. 74% of dual transfer patients achieve muscle strength score greater than or equal to 4 with shoulder abduction versus only 35% if you were to only do one single nerve transfer. Significant, statistically significant. And then these are just like the general mean abduction values that were obtained from the two groups comparing a double versus a single. And they even went to say that if you even have a triple nerve transfer, you even achieve a higher degree of abduction up to 160, which is fairly close to normal at that point, if not normal already. And so in the babies, the approach is slightly different. Spinal accessory nerve to the suprascapular nerve transfer, about 25% achieve motor scale of above a 5 with external rotation versus only 5% with nerve grafting. And so spinal accessory nerve transfer associated with fewer secondary shoulder procedures down the line, especially those secondary ones that come up. And the mean external rotation improvements about 94 for the for the spinal accessory and versus 44 for a C5 graft for that grafting that we can do. So when we're looking at nerve transfer outcomes, when it involves the shoulder in specific, key factors for poor outcomes will be older age, prolonged denervation, and total plexus injuries. So severity, and then your ability to reheal from that, from the past topics we just covered. Now let's talk about nerve transfer outcomes for when we're having difficulty with that elbow flexion. So double Oberlin with ulnar and median fascicles to the biceps and the brachialis branches. This also was another meta-analysis of 688 patients with about 35 studies, showing muscle strength of greater than or equal to 3 was achieved in 97.5 versus 95.6 in a single. So there wasn't really significance when it came to the elbow versus doing a single versus a double. But here's where the difference came. Significantly more double transfer patients achieved a motor strength score of a 4 greater or equal to 4 when perioperative delay was less than 6 months. So the sooner we operate and we do a double, the higher probability of us being able to regain function. Quantitative strength was measured in newtons to show that double is able to build about 4 times as much as strength, so significantly better. Muscle strength of 4 greater than 4 was achieved in at least 2/3 of the patients. First reinnervation signs at about 9 weeks, plus or minus 2, and this is looking specifically at the biceps. It would take a little bit longer, knowing that we inch towards the distance slowly. It would probably be another 11 weeks with a plus or minus 2 for the brachioradialis, knowing the trajectory of healing for the nerves. An Oberlin transfer versus nerve grafting. Odds ratio does favor Oberlin for muscle motor strength of greater than 3 of elbow flexion. Free functional muscle transfer versus intercostal, that will achieve much better as well as opposed to the intercostal. So that has been something that's been explored in the past, but we know that we would have better success from free functional muscle transfers, and those can come from like your legs, or that can come from other parts of your arms, any other muscles that can be active. There's a few that some surgeons have preferential for. Main recommendation for nerve transfer at the elbow level, double fascicular transfers are preferred, and a median nerve preserved if not needed. And so the sooner we do that double, the more successful we will be. Going to the free functioning muscle transfer. So this is indicated mostly when there's a full pan plexus injury. We're talking about the full brachial plexus from a C5 to T1, where nerve transfers are not going to be enough to help us to regain function in that arm. There's very limited donor nerves available, knowing that it's fully involved. Prolonged denervation, these could be long periods. Motor end plates no longer viable for nerve transfer, meaning we take a look at that muscle and really nothing is coming through that nerve to the muscle, no activation. Our goal at this point, if there's a full injury, is to restore elbow function. We want to be able to bring that hand to our mouth and maybe getting some of that rudimentary hand prehension as well to kind of help us out. This is where we're talking about those different muscles, specifically the gracilis is a single stage FFMT, about 75% achieve active finger pull through. Only 25% consider hand function useful, though, for daily activities. So we could be getting extra motor function, but how much of it is actually meaningful and what we can be useful to us? And then 89% required secondary wrist fusion at some point, no flap loss, meaning those secondary surgeries are still likely when you do an FFMT. A double free muscle transfer tends to have superior outcomes. So instead of just using one muscle, can you use two? The DOE procedure. Usually, if you do double, you tend to have much better elbow flexion, finger movement, and but it does require multiple major surgeries if we're looking at multiple movements, and long treatment intervals, extensive rehab. A lot of this is going to be post-operative, where we can help from a rehabilitation standpoint with therapies and being able to guide these recovery trajectories. Also, when is another indication for us to use this, specifically when it's been a prolonged period of time since the time of injury, specifically in a pan plexus injury. It does show that those tend to have the best outcomes as compared to the nerves, yet it's not, you don't get the biggest gains from it, but some gain could be meaningful enough to some individuals. All right, so electrodiagnostic testing, this is where I can come in.
I'm sorry to interrupt, just a quick comment, just for the viewers. We did have a separate session with Dr. Malesi and Dr. Clark on birth-related brachial plexus injuries. So I think that's something else to provide some further background, and they go into a little more detail about the option of nerve grafting. And we had another session with Dr. Hochboard, an orthopedic surgeon, talking about free muscle transfer. So appreciate the overview, and just for the viewers, if you want to go into more detail on these are some other sessions that might be helpful. All right, sorry to interrupt, and please continue.
Of course. So electrodiagnostic testing, like I said, this could be done by neuromuscular specialists and also physical medicine and rehab physicians. What is the role of EMGs and nerve conductions, right? So different types of roles. Role number one, specifically in the preoperative planning, it's specifically to confirm denervation. We do know that brachial plexus is technically a clinical diagnosis, but being able to quantify that degree of denervation is helpful for us to understand what that recovery could look like. And then in that period, depending on how long ago that injury was, it can also give us an idea of where long are we in the reinnervation process based on the changes that we see. The second role would be it's donor nerve assessment, which is technically also considered preoperative planning. This is where we're looking at motor nerve conductions to confirm adequate CMAP amplitudes for potential donors from one area to another. And then row three, post-operative monitoring. So serial needle EMG every 2 to 3 months. And our goal is to, can we see that progression of that muscle turning back on? And so asking the patient to perform both intended joint motion and original donor action that will then activate the motion that we're trying to go for. As for some of the changes that we can see on EMG, those could be your nascent MUAPs, also known as motor unit action potential. They tend to be small and polyphasic. All that means is that there was some sort of nerve injury, and the nerve is now having some new axonal regrowth. And so it is now showing us that irregularity of that new nerve, and it shows us through these small polyphasic waves. The other thing that you can see over time is large amplitude MUAPs. That's usually letting us know that collateral sprouting from the spared axons, meaning those axons that were not injured and those few that were still there are able to regrow little rootlets or sprouts to be able to cover for the area of the nerve that was damaged and is no longer innervated. And so this can be seen by a change in the morphology of the wave as well on EMG. CMAP ratio improvement at 6 months correlates with the muscle strength, muscle strength test change at 12 months as well. Ideal model, like I mentioned, joint collaborative clinic between electrodiagnostic specialists and surgeons. So here at Dell's, I work specifically with the plastic surgeon in his hand clinic. Depending on where we see these kids, the type of injury, we can do all these different types of assessments with electrodiagnostics, and then that gives us the ability to kind of direct the care on where we want to go next and best for serving the patient. So electrodiagnosis in babies specifically at the time of birth. It still remains a little controversial. The things that we're looking at is our sensory nerve conduction studies. They will show a normal sensory nerve action potential and EMG with some EMG abnormalities, meaning this is the main criteria that we need for avulsion. Anytime that we have any sort of injury near or at the level of the root, or that's when we also have to look at the sensory, because the sensory ganglion is a little bit further away from the spinal cord. Normal snaps tends to give us a picture that and normal snaps, but abnormal like motor nerve conduction and EMG abnormalities is enough for us to be able to say that this injury does involve the root level, whether that is an avulsion or right, an avulsion or a much closer injury like a radiculopathy per se. Sensitivity for sensory nerve conduction is pretty high, 90 to 92% for ruptures and postganglionic lesions, like I mentioned. But coexisting pre/postganglionic lesions, if there's something else, the sensitivity of us relying on the EMG for just this, it drops significantly from that 90 to about a half to a fourth for avulsion specifically. So we have to just be careful with how we interpret what information we're getting from our nerve conduction studies. In the EMG, I'm looking more at those muscles that are innervated, C5, C6 kind of thing, the motor unit potentials in the biceps and the deltoids, especially if they're absent, that would normally confirm a 6C level avulsion. Absence of motor unit potentials cannot reliably differentiate pre versus post-ganglionic lesion, unfortunately. It's more of those sensory that will give us a little bit more of that picture. Axonal variability index, which just means it's the CMAP ratio of the affected versus the unaffected, tends to minimize with age and gender confounders. Now, for babies, it's always important to think EMG as a slow prognostic factor may over or underestimate recovery in the developing child. So normally the way that I use electrodiagnostics for babies is to kind of understand, get a general picture of where we're at depending on the time that I'm doing it. Seeing, like I mentioned earlier, are there any of these changes of reinnervation, or is this like a full injury that we should be looking at at surgery sooner? So severity, not necessarily always in diagnosing. Like I mentioned, it's a clinical diagnosis. This is more for just quantifying and trying to give us some data to better understand the level of injury. Just making sure. So rehabilitation, we have two distinct frameworks. For the neonates, those babies, rehab, like I mentioned, begins immediately at diagnosis, not postoperatively. Early range of motion is safe. It does not increase shoulder subluxation risk. Do not move the arm, in quotations, is an outdated paradigm. Postoperative, play-based, milestone-driven, DARPA protocol, which it's going to be on one of the other slides. In the past, we have sent babies home with their arm in a sling, making sure family not to move it, yet that then increases the risk of contractures and not really activating that neuroplasticity, which is available to us. And so there has been a shift from this mindset. Even when I arrived to my institution, the NICU was still saying, don't move the arm. That has changed already. We are implementing these new home exercise programs to get these families started, but by the time they get to clinic, they're already at least having something to kind of help the function and the range in that arm. Now, like I mentioned earlier, specifically for those traumatic ones that are for older and adults, rehab tends to be primarily post-operative. There is a 5-phase framework guided by serial EMG, where we're looking to see, are we gaining, are we not? And then also the inclusion of EMG biofeedback is cornerstone of re-education. This is something that's also been coming up recently, being able to use EMG to help us reactivate and learn how to turn on that muscle again, especially if there's been rewiring. Total supervised therapy for both can be anywhere from like a year to 3 years, meaning that this is, if we're doing any sort of nerve injury, we're looking at a long trajectory. Normally they say about a year after like a brain injury. That's not true here. Here we have up to 3 years after the surgery with trying to get as much function back as possible. All right, so rehabilitation after nerve transfer. Why is it critical for success? So, like we mentioned earlier, nerve transfer require cortical reorganization to establish those new motor pathways. Patient must relearn how to recruit newly innervated muscles. This does not occur naturally. Example, something that I commonly see, and this is, I like how this one was written out. After an Oberlin transfer, the patient must learn that thinking of wrist flexion now produces elbow flexion. Why? We moved that median and that ulnar nerve. Those were for wrist flexion before. We moved them up to the elbow. So if you want to activate those nerves, we need to reteach the body on how to do that. So think about bending that wrist with the hope of producing that elbow function. Without supervised rehab, patients may never achieve functional use of reinnervated muscles. They might not have the appropriate guidance to be able to continue to activate them and get them stronger. Key therapeutic modalities, like I mentioned earlier, EMG biofeedback, that tends to visualize muscle activity before visible movement. So it keeps patients motivated during those months of waiting. So it's possible that the nerve and the muscle is coming back online, and we may have enough current to get through to cause a muscle flicker, but a muscle flicker is not enough to do a whole muscle contraction. And so that is where we don't want to lose or don't want to be discouraged in those difficult moments, knowing that it takes time for that nerve and that muscle to come back online. That even just showing them that, hey, there's this connection, it's going through, it gives them that ongoing motivation to keep pushing through. The next one is EMG triggered neuromuscular electrical stimulation. It does require an active patient participation to initiate stimulation, and it reinforces the donor-recipient connection. So this is something that in babies specifically, it might be a little bit difficult for tolerance, but in adults using some electrical TENS kind of like motor NMES units to help us out in strengthening, that's usually what I say. Stimulation strengthens, splints stretch. That's kind of how I think those two. And then dynamic assist orthosis. So this allows for muscle strength of 2 to perform at functional higher grades. It promotes cortical plasticity through frequent activation. And so splints, stimulation, these are things that I'm reaching for to kind of help in getting more activation from these arms. Fatigue management is critical. Newly reinnervation muscles fatigue very rapidly. We don't have the ability to recruit all those muscle fibers like we did before. And so it's going to take building that endurance, building up that strength. Again, gives us that 1 to 3 year time frame. Exercise demands must match current reinnervation stage. Overloading is counterproductive, meaning meet your patient where they're at. It might be that we're pushing too much, and that might actually be more harmful to the muscle and not allowing it to be able to adapt to the new changes and all. And so having a steady course of therapy and monitoring is important, especially for that pacing and endurance. And then surgeon therapist communication is essential. Operative details, expected timelines, realistic expectations. In our clinic, in our hand clinic, we have an occupational therapist that sees the patients with us in the clinic, and she also does the OT actual therapy sessions with those same patients. So there's that continuity, and we're all in the same room having a meeting of the minds on how best can we serve this patient. So for the neonatal conservative treatment pillars, stretching, maintain passive range of motion, prevent contractures, targeted strengthening, promote functional use of the affected extremity, splinting, whether that's dynamic or static, most statistically reliable intervention along with CIMT, specifically with babies. You put that good arm away and you force them to use the affected arm. CIMT addresses the developmental disregard. It is very common for babies who present with brachial plexus injury to have hemi-neglect almost in a way, because part of their body is not moving. There's no need for me to interact with that side of my body. So they kind of forget that it's there. And so that's why we want to always challenge them to see how can we activate that arm? How else can we strengthen that arm? And then CIMT addresses developmental disregards, improvements comparable to just unilateral CP. So when comparing our cerebral palsy kiddos that have one arm affected to our brachial plexus, we know that brachial plexus will have a much better outcome with the CIMT when compared to the CP population. And that's because it's more of that neuroplasticity as opposed to fighting that muscle spasticity that's present in cerebral palsy. Additional NMES, botulism toxin for muscle imbalance, kinesiotaping, desensitization. Those are all things that I recommend for some of my babies, especially if they can tolerate the NMES units. I've had some good success in reactivating biceps with that. I've also done Botox to the triceps to try to produce, to stop that muscle imbalance, the triceps overpowering our biceps. And I've seen some more increase in activation of those biceps as well from that, even with like just a 2-series Botox and not needing again, because that's all it took to kind of break that pattern of imbalance and get the activation of the biceps, which is really good. Caregiver education, direct teaching, demonstration, video aids for home exercise programs. We have home exercises that we normally provide. We also do teaching of external splints that family can make using like ACE bandages and how to put them on for external rotation and trying to get that arm where it needs to be. We mentioned earlier that hemi-neglect, because we're saying looking to one side, we can develop the risk for torticollis. Again, that's common with my BPI kids, and early speech delays. For whatever reason, it's all connected. I usually, if a kid's coming to me for BPI, I'm just doing my normal developmental screen just to make sure that they're up to par with all their different categories. All right, so with babies, let's talk about the DAR-FAFRA protocol. Donor Activation Focused Rehabilitation Approach. This is adapted for infants and toddlers. It is play-based, milestone-driven, and a 3-phase approach. Compared to the adults, they have a 5-phase approach for their rehabilitation. Donor-recipient re-education through play, caregiver participation. We can include the EMG biofeedback, like I mentioned earlier, but it's more for those older patients who can't tolerate it. Outcomes for those that have gone through the different types of surgeries as mentioned here. It shows that out of the small number of patients that we saw for each of these in this specific study, it does show that with this specific protocol, at least 70% achieve full external rotation against gravity. We do use the AMS scale, Mallet scale, and a 7 is a 7. A full out of 7 is exactly what we want. Motor pectoral, so that's a different kind. To the axillary transfer, that one can show significant improvements in abduction and flexion with a significant p-value. Double fascicular for elbow flexion. The median AMS is about a 6, which is very, very good. Again, our goal is a 7. Biceps, if they're at a 0, they can go all the way up to a 4 in that motor muscle testing with 100% meaningful recovery of elbow flexion. Like I mentioned, anytime that we have any sort of these nerve transfers with the good solid rehab in these babies, they tend to have some really good recovery. Might not always be 100% like it says on there, but meaningful is the main important keyword here. Some function that could be meaningful and useful to the family and the patient themselves. Older children, for the babies, 3 phases. For the older kids, 5 phases. So phase number 1 tends to be your protective, your first couple of weeks, your first month. We're talking about immobilization. This is actually when you put a kid in a sling, but you do some passive range of motion and you control any of your edema management from your initial traumatic injury that caused this type of BPI. Excuse me. Phase 2 tends to be the silent from 3 weeks to until we activate a motor strength of 1, where we're actually seeing that flicker, and or within EMG biofeedback, right? And so that's where it comes into phase 3. So phase 2, passive range of motion continues, mental imagery of donor activation. This is where we don't want them to be discouraged. This is that silent phase where did this work? Did this really not work? It's not until we get that activation that's when we can continue to push and move forward to the next stage. So re-education phase 3, when your muscle motor strength is between a 1 and a 2, and we're not seeing visible joint movement, but there is activation of the muscle. That's where we use that EMG biofeedback, surface EMG visualizes activity before the movement, so you can see those lines, seeing that it's activated even though you're not feeling that movement. EMG triggered NMES, and then donor co-contraction exercises. Phase 4 includes the strengthening. We're moving on up from motor of 2 to 3. Now we're starting to hopefully activate against range of motion, against the range of motion against gravity, donor deactivation, and so trying to turn off whatever we stole from, because now we want to be able to use it where it can be effective. Dynamic assistive orthosis, so having something that actually goes through the movement with them. Dynamic meaning movement as opposed to just static and a solid splint. So that's the strengthening phase. And then again, like we mentioned earlier, the fatigue muscles that are reinnervated after being denervated do fatigue pretty fast. And so once we get to that anti-gravity strength, we're talking about endurance, we're talking about function. This is where we start putting in the weights with progressive resistance, functional sport-specific training, vocational reintegration. So we've gone from no activation to turning the muscle on to strengthening the muscle, and then eventually having that muscle being functional in day-to-day life, in whichever that may be. So key principles for rehabilitation in both populations. Recovery does require more than a year. Like I mentioned, can take up to 2-3 years of supervised therapy. Fatigue management is critical. Denervated muscles fatigue rapidly. Surgeon-therapist communication is essential. Operative details, expected timelines, and then specific for babies, multimodal approach. No single intervention is best alone. Family caregiver engagement is central to success. We need family to buy in. They're the ones bringing the kiddo to and from therapies. Monitor all patients for long-term for glenohumeral dysplasia. Normally, I start screening babies at around like 6 months, unless I have a reason to do it sooner. I'll do a 6-month ultrasound of both to be able to see are they at a risk for dysplasia and/or subluxation kind of thing. And so just keeping a low threshold for those there. And then secondary procedures may include Botox, subscapularis lengthening, tendon transfers, and humeral osteotomies as well, done by either plastics or ortho. All right, so jumping into some neuropathic pain management. So this is very common anytime there is any sort of nerve injury. In the adults specifically, it tends to present at a much higher rate. About 50 to 70% of them do develop pain, and it's found at least in like 90% of all avulsion injuries, they will have some sort of limiting neuropathic pain. Pain often more debilitating than functional limitations. Most common is paresthesias, dysesthesias. Most severe is when they're complaining of that burning that just doesn't go away. Risk factors include total plexus injuries, avulsion, history of smoking and alcohol use, involves both peripheral and central mechanisms, differentiation. And so just kind of giving us a reason for the pain and how it presents in them. In kids, it's not as well studied. It's still an area that we're learning more and more about. For preverbal children, pain may present, they're not able to communicate that they're in pain. So sometimes sensory seeking, like self-mutilation, excessive mouthing, or biting of an affective extremity. It could be sensory seeking that they're looking for oral stimulation, or is it something from the source of the limb itself that they're trying to reduce some sort of sensory input that they're just not liking that they're getting, and they just may not be able to explain it as pain. The one thing that I worry about in babies is that anytime we're trying to do any range of motion exercises with their home exercise program, if there's any sort of like hesitation or inability to tolerate stretches, I will get an x-ray of that clavicle and that shoulder and that arm. Just make sure that there isn't anything that could be the reason for this type of pain, because that would be the only indication that I would probably have to splint a baby with a brachial plexus, is if there's an active fracture. All right, so different tiers for pain, we can go through them. So I'm not a pain specialist, but these are common medications that we use. TCAs, SNRIs, alpha-2 ligands, gabapentin is our main one. In kids, I use it as well, vitamin G. Pregabalin, it's not something I normally use unless I'm like meeting the limit of my gabapentin. When it comes to all these first-line pharmaceuticals, there really isn't a superior class. It's going to be based on what your comorbidities and your side effects are. I personally am not a fan of the TCA side effect profile, so I try to stay away from TCAs in children, definitely reaching more for that gabapentin as it is better tolerated. Combination therapy from different classes may also provide additive benefits. So do we need more than one type of medication? In nerve pain, opioids are not recommended. Pediatrics, we have to do everything dosing weight base. Here we have some titrations. For gabapentin, my main one, I usually start at 10 kilograms per day and titrate to about 30 to 50, 50 usually being my max dose divided in 3 doses throughout the day. It is a medication that was previously approved for epilepsy, but we have a good a good control of pain, nerve pain with this. We all know this now. Side effects, looking for that sedation and hyperactivity. I have seen hyperactivity and behavioral issues with gabapentin, and it tends to happen in the younger ones. Just something to keep in mind. If there's something that has changed, it could also just be a medication that we recently started. Also, additional dosing recommendations for pregabalin and amitriptyline. Key point, paucity of evidence for analgesic effect, safety in children. Extrapolation from adult data is common, but not ideal, meaning we don't have these things studied in kids. Everything is adult-based, and while we try to use that same data, doesn't always correlate directly, but it does give us some idea on where to go to. Tier 2 and 3. So we're talking about topical agents and non-pharmacological interventions. Topical agents, that lidocaine patch is great. I have good success with that. Sometimes even Voltaren gel if it's more joint pain. Capsaicin patches, I don't think that's something that I commonly do. It is something that's explored and studied more in adult patients, and it tends to have really good results in that population. I've seen it be helpful in like spinal cord injury as well. Mirror therapy, phantom pain has reduced from a 10 to 2 out of 10 after even 6 weeks of just using mirror therapy. Graded motor imagery, also shown to have some sort of effective. This could be done through therapies as well, and then a combination of the different things. Psychological support is also important in people with brachial plexus. We have found, especially in the adult population, about a third of them report depression. Half of them experience anger or frustration. I mean, you were able to do something, now you can't. And cognitive behavioral therapy is recommended just with the changes of what we're going through. For babies, desensitization, play-based distraction, caregiver education on pain recognition. In babies, they might not tell us they're in pain. They're going to show us these signs, like I mentioned earlier. And then how do you therapize a baby? Let them play. That's basically the best thing you can do. Just let them go and have fun. Structured therapy time can also sometimes be discouraging, and I've had kids who will freak out as they're getting to the therapy gym, meaning they do not want to be there. And so being able to also provide therapy in an outside perspective and non-formal therapy is important. And that's just play for kids. All right, last tier, interventional and neuromodulation. This is for those pains that we can't control, the refractory ones. And this is where y'all come in. So primary older children and adult patients, we're talking about spinal cord stimulators. High frequency has shown to benefit at about 8 to 13 months. And in addition to spinal cord stimulator plus peripheral stimulation, it has shown to significantly reduce and eliminate that pain. The other one is the last resort, specific for avulsion injuries and avulsion pain. We're talking about DRESS, that dorsal root entry zone. This has shown that in about 917 patients that it's been performed through this meta-analysis, about 70% have significant pain reduction from like about an 8 to about a 2. 10-year follow-up, that pain reduction seems to be sustained, and about 50% maintain complete relief, meaning with the dress, that's probably one of the things that you can get the most effective. More effective for paroxysmal than continuous burning. So with this coming and going, if you're having worse episodes than not, microsurgical dresotomy is preferred over the radiofrequency ablation, in these patients. All right. So multidisciplinary team, peripheral nerve surgeons, PM&R physiatrists, myself, OT hand therapists, PT, pain management, psychology, social work, and then for babies, we're including that pediatric neurologist, pediatric orthopedic surgeon, and speech. Anytime that we're thinking of BPI, just looking and seeing that it's one arm that may be effective, but that one arm is enough for us to bring a whole team of professionals together to try to see how can we best move them along. So team timeline, just in general for both type of populations. For neonatal, I'm wanting that immediate OTPT. I want them as soon as they're getting out of the hospital, trying to just establish, even if it's once a month. I try to get them seen within the first month of life here in my clinic, so then I can at least start the education and the stretches and help with they have not been able to connect with these therapists. At 3 months is usually when I start doing my first set of exams, looking at that Toronto, trying to see, are we having that activation of that biceps? Do I need to engage my friends from neurosurgery? Do I need to engage my friends from plastic surgery? So surgical decisions are kind of coming up in those first several months of life. And then post-operative, if we are to do anything, nerve transfer or free muscle transfers, considering that DAFRA protocol to kind of help us, and continuing ongoing glenohumeral dysplasia surveillance with those ultrasounds of those babies. As for traumatic and older, pre-op, surgeon, electrodiagnostic, therapist planning. So trying to get our pieces together before we know that we're going to commit to that post-operative course. 0 to 3 months post-op, it's that protective phase. We are in that immobilization. 3 to 12 months, we're doing that active reinnervation. We're starting to do the EMG biofeedback. We'll continue to assess with serial electrodiagnostics. Are we progressing? Is our nerves and our muscles improving? Are we seeing those changes on the nerve conductions, all that. And then from 1 to 3 years, we're looking at strengthening, vocational rehab, and checking in on our mental health as well. Throughout this whole period, from start to finish, we are managing pain and psychological support for these patients. Putting it all together. So we'll put it all together for babies and then for the adults. So birth, diagnosis, comes from the NICU, comes from the nursery, immediate OTPT, maintain range of motion. 1 month incomplete recovery, refer to rehab specialty center for us to assess. 3 months, we're looking at, like I said, reevaluate at 6 and 9. So at a 3-month interval, we're looking to see how much are we gaining from a clinical standpoint. At 9 months, if they're not able to bring that cookie to their mouth, they have failed, and now we're talking about maybe some surgeries, and we're having conversations now. And if not, then we're talking about conservative management plus long-term follow-up. If there's no need and they fall under that 66 to 75% that improves on their own, then I still just kind of follow them along. I usually say after the 9-month mark, I say, come back if you have any concerns, but if not, let's at least check in a year to make sure that we continue with our development. DARPA protocol, long-term, all patients, surgical and non-surgical, looked at that shoulder joint, and then outdated mantras, all birth injuries, brachial plexus recover, and wait a year, replaced by early referral at 1 month. The more proactive we are in the earlier intervention, the sooner we catch it, the sooner we can interact, the sooner we have better outcomes as well. Now for the adults and traumatic injuries, we're talking about the first 3 months, detailed history, physical exam. This is the data collection phase. Serial clinical and electrodiagnostic assessments, identify where is our level of injury. might be a little bit easier to get an actual MRI on adults, such as it is on some of the kiddos having to sedate and whatnot. And then assess for immediate pain management initiation. Optimal window for the adults, like we mentioned, tends to be a little bit of a smaller window from 3 to 6 months, but no recovery. If we're not seeing any improvement, no activation, we need to go and explore and see is there something else that is injured. C5, C6, C5, C7, dual nerve transfers, and all the different types of procedures that are available. I won't rehash those again. Post-operatively, then we go through the many different phases, which we already reviewed. They're just laid out here with all one presentation, one slide kind of thing. But I think we've already covered most of these points, so we'll keep going. I think that's my last slide. So take-home points. Important to note, two distinct populations. There's the neonatal, and then there's the traumatic, which tends to be a little bit older in adults. They require two different approaches. Nerve transfer outcomes, we know that double versus single for both shoulder and elbow will have better outcomes. For FFMT, indication specifically for panplexus injuries, a double FFMT achieves better functional outcomes, but requires extensive commitment, more surgeries, more therapies. Rehabilitation is not optional. I'm sorry, you guys are stuck with me. And that's because cortical reorganization requires supervised therapy with EMG biofeedback. Without it, reinnervated muscles may never achieve functional use. They may activate, but it may not be enough. The DARPA protocol for babies, 100% meaningful elbow flexion recovery, neuropathic pain, at least found in 90% of avulsion injuries. Important to start multimodal treatment early and avoid those opioids. Don't need them here. Dress lesioning, durable relief for refractory avulsion pain, and then multidisciplinary collaboration. Bringing all these minds together, all in the same room. Every case is different. Every case presents differently, whether that's in the functional aspect, whether that's the psychosocial aspect, all those all those components mix in together to then contribute to the ongoing journey of our rehabilitation for our patients. And that's all I got. I'm sorry I didn't get to update my contact information, but I can always just go back to the intro slide to have that on there. But that's all I got, and these are my resources.
It's a great comprehensive review, and I agree with you. If you don't have a rehab team, you should not be doing those therapies are a good place to send them. Otherwise, your outcomes are going to be way worse. And, without an intervention from therapies and rehab and identifying them early on will help funnel them to surgical route as soon as possible. So 100% agree with all your points.
Yeah, that was a wonderful presentation. Really highlights the multidisciplinary approach for patients with brachial plexus lesions. Yeah, I was curious if you could talk a little more about your interaction with physical and occupational therapists. I know we're some institutions are not lucky to have a pediatric physiatrist, or even on the adult side sometimes. How do you work with them? Is it more that you're overseeing some of the techniques, or you're working at the same time together?
That's a great question. So when I got here, one of my goals was to work and collaborate with them closely. So I actually reached out to both the acute inpatient PT and OTs. Specifically in the PD world, it'll be more of your OTs working on the brachial plexus injuries. Some of the PTs can help, but it just depends on their comfort level. Sometimes what I'll say is that within the first year of life, PT and OT are doing very similar things, and so it's okay to kind of tap into either one. Having one sort of therapy triumphs having no therapies, and that's because I have someone who's looking at them. So when I got here, what I tried to do is I wanted to meet all the therapists who are engaging with our brachial plexus patients. We have two specific outpatient therapists who are certified in addition in hand therapy. And so they can take on these specific brachial plexus injuries and know how to do many of these different protocols, neuromuscular electrical stimulation. I work with them in making sure if the kid benefits from the device, being able to get them the device so that they can do that at home as well. So those two hand therapists that are in the outpatient therapy, they are also in our multi-D clinic, which is our hand clinic with the plastic surgeon and myself discussing the case. They're the same therapists that do the therapy for the kids so they know them and they've seen that progression over time. Our hospital's not that big, and so I only have 2 outpatient, and there's maybe like 3 or 4 that are in the inpatient side as well. We've been in communication anytime that a baby pops up with a concern for brachial plexus. They reach out to me knowing that I'm going to be the one to take it over. They were the ones who shared with me their initial recommendations, and that's when we looked at it and we're like, actually, this is outdated. That paradigm that we need to wait for a year is no longer. And so I came in maybe like 2 years ago, and we've now changed even like the home exercise program of what leaves the NICU and the nursery to match more updated recommendations. And so they know that they start everything on the inpatient side, they introduce it, but then I catch them within the next like 2 to 3 weeks from after discharge, so then I can then take on the rest. So yes, I work with them at different levels, both the acute, the outpatient within the clinical setting, or even if it's just being able to discuss the case back and forth, email or cases and all. So
Great. And I found it very interesting, the EMG biofeedback. Do you know if is that something that is readily available to community PTOT, or is that something that's maybe more expensive and requires more training?
definitely. So EMG biofeedback will require a little bit more training. I think that's where those hand therapists have that insight. And so they know what type of protocols to use within those devices, and then knowing how much to increase by, intolerance wise, and all, what to look for. And so those hand therapists are usually trained in that. But even then, that's hard to come by. And I think, like you said, it's the feasibility and the availability of it, and then knowing how to use it is the other thing. And so I myself am within the electrodiagnostics and the neuromuscular aspect of pediatrics. And so to me, I feel very comfortable with like TENS unit, neuromuscular electrical stimulations. I'm even having conversations with the surgeon where he's like, that won't work. And I'm like, actually, there's some new studies and this is what it's saying. I think it doesn't hurt. If it doesn't hurt and it helps, let's try it. And so I'm of that mindset that, and then if we do get some activation with stimulation, which is strengthening, that's what we want. We keep pushing that forward. We keep activating those muscles. We keep getting stronger.
Right. You touched a little bit on splinting. I have patients sometimes with an ulnar nerve injury, let's say, maybe even separate from brachial plexus, where there's finger curling. Can you give us just a brief overview about when to refer those patients and the types of splints you would create for them?
Yeah, so splints can be many different types. It could be something that could be custom made by the therapist themselves. Could be something that I would order from an actual vendor, orthotics or prosthetics company. That does take a little bit longer. Now, the question would be, what are my goals? So if I have a claw hand from an ulnar injury nerve, let's say, and we're starting to get stuck, losing range of motion. So are we talking about positioning? So do I need to stretch the hand out in order to prevent those contractures from happening? Then I'm thinking of a splint for overnight time. I also mentioned some dynamic splints in there. Dynamics is the ability to be able to, like, let's say you have that weak ulnar muscles. Can you have some sort of tenodesis splint that kind of helps you in opening your hand and your fingers and practicing that movement? It's almost like when we put kids on a treadmill that can't walk, but we're stimulating walking in a sense for them to try to reconnect that cortical, that neuroplasticity, and trying to get that active. So it could be, is it for positioning? Is it for usage? If it's usage, we're thinking more dynamic. Are we thinking a daytime brace? Are we thinking a nighttime brace? Normally for brachial plexus in the babies, braces that I commonly do would not necessarily be closer to the wrist. I'm looking more at upper extremity. More proximal extremity. So elbow immobilizer, specifically if I'm having some biceps contracture. I can use an elbow immobilizer for overnight to stretch that. And I can use that same one on the opposite arm during the day, on the good arm, to activate the CIMT and get that affected arm a little bit more of functioning and working. So elbow immobilizers are common for me. The other one that I could use is there's different versions of it. I got trained on what we call the superhero splint. It's basically an external rotator of the arm. It's a splint that's just basically ACE bandage with some traction to pull that shoulder out into external rotation. What happens if we stay stuck in a certain place? We lose that range of motion. That's not what we want. We want to be able to move and keep that range. And so I'll see intermittent usage of that external rotator plus the elbow immobilizer. Hands for kids, it's a little bit different where I want them exploring. I want them using it because that's how they're going to start to learn and play. Adults, again, it goes back to that. What is our goal? Splints for stretching, stimulation for strengthening, and then the splint, are we looking at for active day use or are we looking for something of contracture prevention? So it goes back to what is our goal for that brace, and then making sure we watch it, right? Because we know that with brachial plexus, it can potentially, not always, but it can sometimes include your sensory nerves. And if that happens, then we also need to be thinking of skin injuries, especially if we're putting a brace on a place for too long. No pressure injuries developing, and then so educating family, check your skin, make sure all that's good.
Thank you. That's great to hear the principles and decision making. Dr. Rizk, any other questions?
No, we're fortunate to have Dr. Lara here. As you can see, he's our champion for brachial plexus injuries. Wonderful job. We're so excited with all the progress that he's doing, and our brachial plexus, clinic continues to soar. So thank you so much for all the wonderful innovation and up-to-date practices that you're bringing into our patient population.
Of course, thank you.
Yeah, and thanks for sharing everything with us. All right, take care.
All right, have a good one. Bye.
That's a great talk. Thank you so much.